Welcome back to This Week in Pulmonary and Critical Care Medicine. I'm your host, Dr. Aladdin Sagar. Today's episode features 3 studies that matter directly to bedside practice. We start with STORM-PE, the first randomized trial evaluating mechanical thrombectomy plus anticoagulation versus anticoagulation alone in intermediate high-risk pulmonary embolism. This trial finally gives us comparative data in a space dominated by single-arm studies. Our second article looks at a biomarker-guided steroid strategy for hospitalized asthma exacerbations, a pragmatic randomized trial evaluating whether eosinophils can safely shorten steroid exposure. And we close with a comprehensive review on non-invasive respiratory support, highlighting practical nuances in high-flow nasal cannula, CPAP, and BiPAP that clinicians often overlook. As always, this episode is for medical education only. All links to the original manuscripts are in the description. Let's get started. Published in Circulation earlier this year, the STORM-PE trial marks a milestone in PE management. For years, clinicians have relied on observational studies to justify the use of mechanical thrombectomy in intermediate high-risk PE. We've seen consistent improvements in RV size and overall hemodynamics, but we never had a true comparator. This study finally gives us one. STORM-PE enrolled 100 patients across 22 international centers. All had symptom onset within 14 days, were normotensive at presentation, and showed both RV enlargement, an RV to LV ratio of at least 1, and elevated cardiac biomarkers. These are the patients who look stable in the emergency department yet carry a real risk of crashing hours later. They were randomized to anticoagulation alone or to anticoagulation plus computer-assisted vacuum thrombectomy using the Lightning Flash 16 French system. The primary endpoint was the change in RV to LV ratio at 48 hours, measured by a blinded core lab. The result was unmistakable. Patients receiving thrombectomy had, on average, a reduction of 0.52 compared with 0.24 in the anticoagulation-only group. That difference of 0.27, with a confidence interval well above 0 and a p-value below 0.001, represents a clinically meaningful acceleration in RV recovery. It mirrors what we've seen in single-arm trials, but this time with the strength of a randomized comparison. Thrombectomy also produced more rapid improvements in pulmonary artery obstruction scores and in vital signs. Heart rate, oxygenation, and blood pressure trends normalized earlier, reinforcing the physiologic impact of removing clot burden rather than waiting for anticoagulation alone to do the work. Safety, of course, is the other half of the story. Major adverse events occurred in 4.3% of the thrombectomy arm and 7.5% of the anticoagulation arm, a difference that did not reach significance. 2 PE-related deaths occurred in the thrombectomy group, a signal worth noting, although the trial was never powered for mortality. Bleeding rates remained low. What this study really tells us is that thrombectomy accelerates RV recovery without an accompanying surge in early complications. For clinicians, the implication is practical. In patients with significant RV strain, rising heart rates, worsening dyspnea, or borderline trajectories, selecting thrombectomy becomes far easier to justify. We still need larger trials to know whether faster RV normalization translates into fewer decompensations, fewer ICU transfers, or better long-term outcomes. But STORM-PE clearly shifts the conversation. It brings us one step closer to identifying which patients truly benefit from early mechanical intervention. The second study, published in Thorax, confronts a problem every clinician recognizes. Hospitalized asthma exacerbations often receive 5 to 7 days of systemic corticosteroids simply because that's what guidelines have long recommended. Those recommendations, however, rest on surprisingly thin evidence. This randomized trial asks whether we can use a simple biomarker, the blood eosinophil count, to safely shorten steroid duration. The investigators enrolled 110 adults admitted for asthma exacerbations, all of whom had baseline eosinophil counts checked before receiving any systemic steroids. Patients were randomized to usual care, meaning a fixed 5-day course of prednisolone, or to an eosinophil-guided strategy, in which the duration depended on the initial eosinophil count. If eosinophils were 300 cells per microliter or higher, the standard 5-day course was used. If the count was below 300, the course was shortened to just 3 days. The primary outcome was treatment failure, a composite that included extension of steroids, mechanical ventilation, or death, and the results showed non-inferiority. Treatment failures occurred in roughly 11% of the eosinophil-guided group and 7% of usual care, producing an absolute difference of just 3.6%, with a confidence interval that stayed within the pre-specified non-inferiority margin. But the more interesting story lies in steroid exposure. In the eosinophil-guided group, patients with non-eosinophilic exacerbations received dramatically less steroid, about 136 milligrams cumulative, compared with 214 milligrams in eosinophilic exacerbations. That distinction vanished entirely in the usual care arm, where everyone received essentially the same dose regardless of biology. Other outcomes remained similar between groups. Length of stay didn't change. Symptom improvement based on the ACQ-5 was comparable. Additional steroid bursts within 14 days were no more common, and over 12 months, time to next exacerbation was also the same. What emerges from this trial is a pragmatic message. A shorter 3-day course appears safe for non-eosinophilic exacerbations, which are typically less steroid responsive. This aligns with what we understand about asthma phenotypes and supports the idea of steroid stewardship, using enough steroid for benefit, but not so much that cumulative harms rise over time. For day-to-day practice, this trial empowers clinicians to individualize therapy. If a hospitalized asthma patient has eosinophils below 300 and is clinically improving, shortening the course to 3 days is reasonable and evidence-based. For eosinophilic exacerbations, 5 days remains a sound choice. It's a small shift with potentially significant long-term benefits. The final article this week is a comprehensive review published in Critical Care, focusing on high-flow nasal cannula, CPAP, and BiPAP in acute respiratory failure. What makes this review valuable is its attention to the details we often gloss over: the interaction between physiology and interface, the role of technical settings, and the subtle ways in which these modalities succeed or fail at the bedside. Starting with high-flow nasal cannula, the authors underscore how flow drives physiology. As flow increases, FiO2 delivery stabilizes, dead space washes out more effectively, and a modest but meaningful positive airway pressure, typically between 1 and 4 centimeters of water, improves end expiratory lung volume. In hypoxemic respiratory failure, the recommendation is to start at 60 liters per minute to maximize these benefits. In contrast, hypercapnic patients often do just as well with 30 to 40 liters per minute, as higher flows add little in terms of additional CO2 clearance, while potentially increasing the sensation of resistive breathing. The review also highlights patient comfort, noting that patients often tolerate lower high-flow nasal cannula temperatures, such as 31 degrees Celsius, better than the traditional 37, despite slightly reduced humidification. Asymmetrical cannulas, an emerging technology, appear to enhance airway pressure and CO2 washout by altering flow dynamics between the nares. With CPAP, the review returns to fundamentals. PEEP increases end expiratory lung volume, reduces atelectasis, improves VQ matching, and enhances oxygenation. It also reduces left ventricular afterload by diminishing large negative intrathoracic swings. But CPAP's benefits occur only within a sweet spot. Too little PEEP fails to recruit. Too much PEEP raises pulmonary vascular resistance and worsens RV afterload. This U-shaped physiological relationship is especially important in patients with borderline RV function. BiPAP brings added complexity because it layers pressure support onto PEEP. This reduces inspiratory effort, increases minute ventilation, and lowers CO2. It is especially effective in COPD exacerbations where air trapping, intrinsic PEEP, and diaphragmatic flattening all elevate the work of breathing. Yet, in de novo hypoxemic respiratory failure, some patients fail to reduce their inspiratory effort even with pressure support. When that happens, tidal volumes rise, transpulmonary pressures climb, and the risk of patient self-inflicted lung injury increases. A reminder to monitor not just the numbers on the ventilator, but the patient's actual breathing pattern. The review touches on practical issues as well: mask fit, leak management, and interface choice, especially helmet versus face mask, can dramatically alter patient comfort and synchrony. Esophageal pressure monitoring remains underutilized, but can clarify whether a patient is truly unloading their respiratory muscles. An electrical impedance tomography is emerging as a useful bedside tool to detect pendiluft and regional ventilation shifts. The overall message is straightforward. Non-invasive respiratory support succeeds or fails based on the minutiae. Flow, pressure, temperature, interface, and monitoring all interact. By understanding the physiology behind these interactions, clinicians can deliver these therapies more safely and effectively. That wraps up this week's review of the evidence. As always, the goal is to bring the most relevant and practice-shaping studies straight to your headphones in a way that fits into the rhythm of a busy clinical week. The science keeps moving, and the only way to stay ahead, whether at the bedside, in procedures, or in decision-making meetings, is to keep the evidence in front of us. If you found this episode useful, consider checking the links in the description to read the full articles yourself. And if you'd like regular updates, make sure you're subscribed to the channel so you don't miss the next episode. Thanks for listening, stay safe, and I'll see you next week on This Week in Pulmonary and Critical Care Medicine.